Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 66th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Modernizing Hip and Knee Replacements, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Hip and knee replacement techniques continue to evolve with innovations that enhance patient care before, during, and after surgery. From advances in surgical approaches to improved recovery protocols, these updates are changing patient outcomes for the better. Tonight, IBJI's Majd Tarabichi, MD, will teach us how modern joint replacement techniques are improving outcomes and enhancing mobility for patients. Dr. Tarabichi is a board-eligible orthopedic surgeon who specializes in adult reconstruction for hip and knee arthritis. He sees patients with all types of degenerative conditions of the hip and the knee, as well as patients with complications from prior joint replacement. Dr. Tarabichi takes a comprehensive graduated approach to the diagnosis and management of hip and knee pain and generally starts with non-operative treatment. He likes to think of taking care of his patients as joint decision-making, where Dr. Tarabichi presents the options of what he thinks of as reasonable treatments for each individual based on the severity of their hip or knee arthritis and the degree of disability or pain, and then together, he and his patient come up with a treatment plan. Once a decision is made, Dr. Tarabichi incorporates the latest advancements in perioperative pain management, surgical reconstruction, and recovery. Dr. Tarabichi's areas of expertise include anterior approach total hip replacement, revision total hip and total knee arthroplasty, same-day outpatient total hip and total knee replacement, total hip and total knee arthroplasty, and total joint reconstruction. According to Dr. Tarabichi, classically we think of older people when we think of joint replacements, but what we are finding is that patients with arthritis are getting younger and younger. As you might imagine, patients see Dr. Tarabichi when they can no longer engage in the activities they enjoy, and many are in profound pain. What makes him get up and go to work every day is the knowledge that he can take patients from significant disability and pain to being totally pain-free and fully recovered back to doing the things they enjoy. Following completion of his medical school training, Dr. Tarabichi spent 2 years as a fellow at the Rothman Institute at Thomas Jefferson University, where he performed award-winning research with some of the thought leaders in the field of hip and knee replacement. Dr. Tarabichi has won multiple awards for his research, including the John Insull and Otto Affrank Awards, two of the highest honors in the field of adult reconstruction. He completed his residency training in orthopedic surgery at the University of Illinois, Chicago, followed by a fellowship in an adult reconstruction at the prestigious University of California, San Francisco. During Dr. Tarabichi's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Tarabichi immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Tarabichi via one of the options that will be listed on the slide shown during the Q&A portion of the program at the end of his presentation. Two more things before I turn the evening over to Dr. Tarabichi. First, please mark your calendar for our next IBJI and YMCA Education Series program. On Tuesday, September 16th at 7 p.m., Dr. Dejuro Petrich will discuss the aging shoulder in an active adult. What's normal, what's not? And second, I hope you'll join us on Wednesday, September 17th, in person for Senior Palooza at the North Suburban YMCA at 12 p.m., when IBJI's Dr. Ryan Harold will discuss common shoulder, elbow, and hand issues. Then, following Dr. Harold's presentation, join us from 1 to 3 p.m. for the Health and Fun Fair part of Senior Palooza, where IBJI physical therapist Donna Ishak will be offering free balance and fall risk assessments. Plus, another 70 or so vendors will be on hand to answer your questions about nearly everything related to aging gracefully. There will be raffle prizes and a whole lot more. To learn more about Senior Palooza, visit the NSYMCA's website. Thank you again for joining us tonight, and thank you, Dr. Majd Tarabichi, for your time and effort in putting together this program to tell us all about modernizing hip and knee replacement. Dr. Tarabichi, please take it from here.
All right, thank you so much, Karen, and thanks everyone for joining us tonight. All right. So yeah, our topic tonight, is about, what the most recent advances in hip and knee replacement. We'll do a brief primer about, the fundamentals, just so, everyone has a, basic understanding of what we do and, the advances and so forth. So, these are my practice locations. I see patients in Bourbonnais, Tinley Park, and Frankfurt. So we'll start with the basics, okay? So, the most common reason we do joint replacement of the hip and knee is arthritis, and most commonly it's called osteoarthritis, which is essentially wear and tear. So if you look at, this X-ray of the hip and the knee, you can see how the head is sort of nice and spherical, and there's a nice smooth surface, and that's basically indicates the presence of cartilage, which basically allows for a nice smooth gliding surface. And similarly in the knee, you can see how there's a nice open space there, and that's because we can't really see cartilage on X-ray. And as you can see, when that cartilage starts to wear away, then the bone starts rubbing up against the bone, and that's what causes the pain that eventually leads to the crunching, the swelling, and ultimately what leads patients down the road to joint replacement. Now what we know is that the X-rays and what patients feel don't always correlate. We can find patients who are walking around with really, horrendous looking arthritis on X-rays and are not feeling any pain. And so patients maybe with milder disease who may have a lot of pain. So what's important is that we always treat the patient. The X-ray, what the X-ray looks like is important, but the most important thing is how the patient tells us they feel. Okay. So, we got this question quite a bit. And so when we replace the knee or hip, what are we actually doing? The technical term for a joint replacement is an arthroplasty, and that basically, arthro means joint and plasty means reconstruction. And it basically means just replacement of the diseased joint surface with a prosthesis. And that's typically a combination of metal, which is either what's a combination of cobalt and chromium, as well as titanium, and a medical grade plastic and ceramic. And I think, sometimes replacement can be a bit of a misnomer because, sometimes I think patients get the idea that we're sort of lopping off the joint and we're replacing it with metal. But really, we'll go into a little bit more. So when you look at the hip, basically, it's composed of the acetabulum, which, if you think of the ball and the socket, that's the socket. And then there's a liner that goes on the inside of that, which is that medical grade plastic. And then there's the femoral stem, which is that metal pin that goes down your thigh bone. And then the sort of the femoral head, which sits on top of that stem and then articulates and sort of provides a very nice gliding surface to articulate with that socket. And typically these are sort of put in a cementless technique. And really what that means is that we're basically creating a space within the bone that is slightly smaller than the actual component. And so when we wedge it in, it's by nature of that, that difference in size, it wedges in and eventually the bone grows into it. In some patients, wedging in implants may lead to fracture, and we know that in older patients with osteoporosis, that can certainly be the case. And that's when we use things like cement. But by and large, hip replacements are put in a cementless fashion. Okay. And so this is what we were talking about. So that this is an X-ray of a pretty typical modern hip replacement that's being put in all over the country. And like we said, there's a socket, there's a plastic liner, and then a femoral head. And this, I think, nicely illustrates how those basically go into your body. All right. And then the total knee replacement basically is composed of sort of three compartments or three parts of the knee: the medial part, which is the inside of your knee; the lateral part, the outside of your knee; and then the patellofemoral joint, which is basically the part where your femur bone or your thigh bone articulates with your kneecap. And then in terms of the parts of the knee replacement, basically it's the femur. So basically we shave off the bottom of the femur bone and place a metal cap on it. And then the tibia, we shave off the top of the tibia bone and then place the metal cap on it. And then there's a liner, much like the liner in the hip, which is plastic. And then we'll talk about this a little bit more, but most people will shave off the back of the kneecap and place a button. And conversely, in the knees, cemented knee replacements are far more common than cementless knee replacements, although we'll talk a little bit more about why cementless knee replacements are actually increasing in popularity. Okay, and this is an x-ray of what a modern knee replacement looks like. So that's that, the femoral component, the tibial component. You can't see plastic on x-ray, so the x-rays go right through it. So that's why it looks like it's just air in between those two. And then you can see that there's that sort of how the back of the kneecap is sort of nice and straight, and that's because there's a plastic button on it. And this basically shows, arthritis, so wear and tear, the cartilage, which is that nice white stuff, eventually wears down to bone. And then when we replace it, this is what it looks like. All right. So what are the implants made of? I think, like we said, the majority of the hip replacements are what's called a press fit, which is basically where we wedge them in. And they have these pores, which allow the bone to grow into them. And, hopefully the plan is that lasts for life. And then in knee replacements, the majority are actually attached to the bone with cement. And then the femur is typically made of what's called an alloy, or a combination of metals of cobalt and chromium, typically the part on the tibia, which is made of titanium, and then a plastic liner. So, when do we know if you're a candidate for a joint replacement? So basically, you have to have failed non-operative management. And I think it's a little bit beyond the scope of the talk to talk about this, but basically the 90% of that is physical therapy and injections. Pain that limits your activities, either whether it's your activities of daily living or just, things that you enjoy doing with you and your loved ones. You're unable to enjoy life of the joint. So basically we ask this by saying, is life intolerable at this point? And then x-ray evidence of significant arthritis, and then comorbidities, which is basically, other diseases in your body that may affect the success of the joint replacement. As long as those are under control and you satisfy those 5 conditions, then you are a candidate for a hip or knee replacement. But the most important thing is patients tell me when it's time, okay? I think the one thing people need to understand is that this is an elective operation, and that the patient decides when to have it done. And really that's the most critical thing, is that, even after we talk about those 5 conditions, I tell them, do you feel like you want to have this done? So that's the most critical thing is the patient buying into this and into the surgery and deciding that they want to have this done. I think I put this in here because this is a pretty common question, and I think patients want to know, should I get this done before I'm older? And what we know more and more is that age is just a number. This is a quality of life decision, and we know that the outcomes of surgery are generally not affected that much by age. Patients do very, very well even when they're older. We know with the anesthesia techniques that we have today, we're able to do this operation very, very safely. And actually, your actual health is a lot more important than age, right? So even if you're 80 or 90 years old, but you take care of yourself and you're in good health, and you satisfy the conditions we mentioned, you're still a candidate for a joint replacement. The most important thing I want to mention here is that this is a little bit of medical jargon, but there's no prophylactic or what we call preventative arthroplasty, right? So we never do a joint replacement because we're worried about what's going to happen in the future, okay? Because we know that doesn't do very well. We only do joint replacement when patients have significant arthritis that is affecting their daily lives, and they have basically, for lack of a better term, failed non-operative treatment, or they're at a point where the non-operative treatment is no longer helping. Okay, so I think that's a really critical thing to understand. Are you doing more damage by waiting? Okay. So what I always tell people is that, arthritis is going to do what it's going to do, whether you are active or not. Obviously activity may affect pain, but it's not going to affect the degree of or the progression of the arthritis. Okay. We know that weight is important and potentially genetic factors. And what we know is that highly active patients generally make it longer with an arthritic joint than inactive patients. So we always recommend that people, are active to as much as they can tolerate. And we know that when we looked at this basically in long distance runners, they actually have lower rates of joint replacement than the general population. And so it's really important that, we encourage patients to be as active as possible, as long as they're comfortable. Okay, so, since we've gotten through that, I think we're going to jump right into the advances. I think one really hot topic is robotics. And so, I think it's a really important, what do we mean when we're talking about robotics? And when someone is having a so-called robotic procedure, it's important to understand that the surgeon is still doing the operation as in full control of all the steps of the operation, okay? The other thing that's important is that, you know, for lack of a better term, this has been marketed, quite a bit, but there's no studies really that show that robotic hip or knee replacement actually does better. But what I will tell you is that, you know, there are surgeons who do all robotic hip replacement and knee replacement. There are surgeons who don't use robotics, and, you know, they both types of surgeons get very, very good results. It's just, I think it's largely a matter of preference, okay? There are some risks with robotic hip replacement. As you can see, basically they do have to put pins in your thigh bone and your leg bone to sort of map out where everything is so that the robot knows where the knee is in space. And we do know that, you know, potentially those can cause infection. So it's another source of infection, and even sometimes a source of fracture. Fortunately, the rates are pretty low, but it's just something to understand that, you know, it's another thing we're putting into the body. And so that it's another source of things that could potentially go wrong. I'd like to, you know, we like to compare it to a GPS system. I think, you know, the robotics, it can give you some insight into how the knee, you know, is functioning and what's going to happen down the road in the procedure. But, you know, I always like to think if you're driving from point A to point B every day, you don't really need a GPS, right? So, and similarly, you know, we're doing hips and knees all day, every day. And so for most surgeons, I think it's not a necessary tool, okay? And so I think that's the analogy that I like to use. And then we'll go into anesthesia. So there's really two ways of doing a joint replacement in terms of anesthetics. The first is spinal anesthesia and then general anesthesia. So classically, you know, we did general anesthesia, which is basically where patients go to sleep and they are, you know, they put a tube down your throat and they put you under, okay? Spinal anesthesia is where they inject some numbing medication into your back, and that basically numbs you below the waist for a couple of hours. And this has really, you know, come to the fore, and it's become very, very popular because we know it actually leads to decreased blood loss, less nausea, less vomiting, a little bit of a faster recovery. Obviously, not everyone is going to get spinal anesthesia. You know, patients with a previous history of spine surgery, sometimes it's a little bit harder to do a spinal anesthetic on them. But overall, you know, plenty of studies have looked at this, and we know that now spinal anesthetics are safer. Patients have a lower length of stay. They have fewer complications. And so it's become, you know, the preferred method for anesthesia for joint replacements. I think what patients need to understand is that, you know, you're not going to remember anything. You are awake for the spinal, but generally when the anesthesiologists are working on you, they are giving you a sedation medication. And so you're not going to be awake during the entirety of the procedure. It's sort of a twilight, and you won't remember any of it. And patients, you know, are very, very comfortable during the procedure. Okay. Another advance that's come out really is partial knee replacement, okay? So partial knee replacement is, you know, if you compare it to a total knee replacement, you know, you're only replacing essentially the worn out part of the knee. So if you see here, this part of the bone is touching up against bone, while this outside part is still relatively well preserved. And the analogy I like to use is a car, right? When you have a flat tire, we're not replacing all four tires, we're only replacing the flat tire. And we know that because we're only replacing the affected part, we're leaving the rest of the knee intact. And so we're actually finding that patients who are candidates for this actually, you know, recover much quicker, and there's actually lower risk of complications than a total knee replacement. And so and the indications are expanding. So basically, we're doing this in more and more patients because we're finding that patients are doing better and better, even when they have sometimes a little bit of arthritis in other parts of their knee. And it's become a very, very popular option. Not every surgeon offers this procedure. You know, fortunately, you know, at Illinois Bone and Joint, we have a really high number of what we call subspecialists, so surgeons who just specialize in joint replacement. And I think a lot of us are doing this, and we're doing more and more of it. And so because we're only, you know, putting in smaller parts, you know, there's less bone and soft tissue dissection. There's less blood loss. We know there's fewer complications. Patients recover their range of motion a little bit faster, and there's better range of motion overall. Now, the one thing we have to understand about a partial knee replacement is there is a slightly higher rate of revision, which is a repeat or a redo, where we have to convert patients to total knee replacement. What we do know is that, it's slightly higher, but what we're finding out more and more now is that because we're giving patients, this less invasive option, if we can give someone 10 to 15 years of a more natural knee before we convert them to a total knee replacement, I think that's a huge win, number one, because patients have a more natural feeling knee. And what we're finding is that, it's actually when you convert patients from a partial knee replacement to a total knee replacement, it's largely behaving, like a regular first-time total knee replacement. I think this is a little, outdated, but we've actually found just very, very recent studies where, the recovery from a conversion from a partial to a total is very similar to doing a first-time knee replacement. Okay. And then the other thing is that as we do more and more of these, we're finding that, the survivorship or that's a fancy term for how long they last is, getting better and better. So it's not really a bridge to a total knee replacement. We're finding that this is a procedure that stands on its own and is sort of standing the test of time. And we're hoping, patients will, this may be their last operation when we're not thinking of this as just a bridge operation to a total knee replacement. All right. In terms of total knee replacement, we have longer lasting components. So we know the materials that we're putting in are lasting a lot longer. The plastics that we're putting in are a lot more robust. Okay. And we just know that the overall, survival of these components is getting better and better. In terms of cementless versus cemented, as I mentioned, most knee replacements being put in the United States are cemented. But what we know is that as patients are getting younger and younger, we know that, we're looking for ways for the knee replacement to last as long as possible, because we know with cemented knee replacements, eventually they may potentially loosen, and this was not an issue where we were doing knee replacements on older and older people and those prostheses were outlasting them. But now we're doing knee replacements on younger people. And so we're trying to look for ways, where we can put in a knee replacement that will hopefully last someone their entire life, even at the age of 50 or 60. And that's where cementless components come in, where basically, like we said, just how we're wedging them in on the hip, we wedge them in on the knee. And the idea is that after 6 weeks, the bone bonds to the implant, and we think that bond is hopefully going to last patients for the rest of their lives. We do have new implant options, so we have implants that are more and more bone conserving, so we're having to cut less and less bone to put these in, and I think that's a good thing, just in general, but also if someone ever needed to have a redo procedure down the line, we know that if we're conserving bone, it makes that procedure much easier. The thing is the patella. As I mentioned, we shave off the back of the patella and we replace it with a plastic cap. We're actually finding that, that may not be necessary. And a lot of surgeons these days are actually leaving the kneecap alone, because we know that, we're starting to realize that it may not actually make a difference, and it may actually reduce the risk of complications. So by leaving someone's patella alone, leaving them with the patella God gave them, we may actually be reducing the risk for a potential complication. So that's actually something that's become a lot more popular nowadays. Okay, so we're moving on to total hip replacement. I think this is something that, patients are learning more and more about. So the first thing I want to point out is that regardless of which approach you get, okay, at 6 to 12 weeks, hip replacements eventually all do the same. So there is slightly improved recovery with what's called the anterior approach. And we know patients basically get off walking aids a little bit faster, but by the time you get to 6 weeks, they all basically, sort of do the same, okay? And so there's the anterior approach, which is basically the one that's sort of is now the most common way to do a hip replacement in the United States. And then there's the lateral and the posterior. I would say historically the lateral was the most popular. That's sort of gone away. The posterior was the most popular approach for a while, but now I would say 50 to 60% of hip replacements done in the US are now done anterior. As we mentioned, the implant types, there's the press fit where basically you're wedging it in. And then there's the cemented where you're using cement to sort of have the implant bond to the bone. typically if you're having it done lateral or posterior, you're being positioned on your side during the surgery. So I think one thing patients, may ask after surgery is, I was like, why does my shoulder sometimes feel a little sore or anything? And sometimes that's due to position changes during the surgery, and that usually is pretty transient. When we're doing the anterior hip replacement, patients are, laying down on their back. Some people may not use a specialized table. Some people do use a specialized table to sort of manipulate the legs in space to help perform the operation. Okay, this is a personal interest of mine. So conventionally, hip replacements are done through a longitudinal incision. We know now that sometimes in some patients, that incision can get up into that sort of, skin crease right where your groin is, and that area is subject to a lot of tension and can potentially lead to, a small risk of sort of wound breakdown and things like that. So we've actually moved to what's called a transverse incision. It's not very common. It's something I've started doing recently. And we know that the way that your body orients the fibers of the skin, this is a lot less tension, and it heals very nicely. And so, colloquially, this is called a bikini incision. I know it sounds a little gimmicky, but we do know that it actually heals nicer. There's less wound issues after surgery. You can do a hip replacement just as effectively. And this is something I've been doing. It's still not very common, but I think patients really like it because eventually over time, it really blends into the surrounding skin. And at 1 year, some patients won't even notice their incision. It really heals very nicely. And I've been very happy with it since I transitioned a few months ago. All right, so we'll talk a little bit about what happens during surgery. So tourniquets, I think, are something that are still pretty popular. I think most knee replacements being done in the U.S. are still being done with a tourniquet. Doing it without a tourniquet has become a little bit more popular, but there's been a lot of studies now which actually show no difference. You may notice that, with the tourniquet on, there's a little bit of pooling of the blood. And so we can actually, tell how much patients are moving, because typically if the blood is pooling in your legs and your ankle and the bruising is your leg and ankle, we know patients have been moving around a lot. But, if the blood is pooling in sort of their buttock and sort of, their hamstring area, we know that they haven't been moving all that much. In terms of incisions, I think, there's that so-called minimally invasive incision and a traditional incision. This was very, very popular in, the last 2 decades. What happened is that, a lot of the adopters of the minimally invasive incision, I think what happened is that, it was such a small window to operate through. I think there was a little bit of a higher risk of complications. And so I think there's been a move back to the traditional incision because eventually we want to be able to safely put the parts in and give someone a good knee. And so I think, and especially with robotics, now that we're putting in pins, some surgeons are putting the pins in the incision, and so that incision has to be a little bit bigger to sort of put those pins in. And then in terms of getting into the knee, a lot of patients ask, do you cut the tendon during, to get into the knee? I think ultimately you do have to, cut, whether it's you're cutting muscle or tendon, you have to get into the knee to do the operation. And we do know that even when you're sort of doing so-called, a muscle sparing technique, by 6 weeks, these all perform the same. There are very, small marginal differences between these techniques. So, regardless of what technique you get, as long as the knee is done well, you will have a very good knee replacement. All right. The 2 things I want to touch on here in particular, like I said, positioning. I think, we have to manipulate the knee in space to sort of get the parts in, and that can lead to a little bit of soreness. And then in terms of wound closure, I think the vast majority of surgeons have actually moved away from staples and, stitches. We do a nice, plastic surgery sort of closure under the skin where there's no stitches that need to be taken out after surgery. And we also use sort of a glue called Dermabond to sort of hold everything together. And it really provides a nice cosmetic closure, and we don't have to take out any stitches. And we've actually found that, when we do that, we actually preserve the blood supply to the skin better, and so it actually heals better. And then in terms of irrigation, I think this is something that, has come a long way in the last, few years. We're trying to really reduce the risk of infection as much as possible, and we're getting very, very close, I think, to this being an extremely rare event. And I think what the balance that we were trying to strike is being able to kill bacteria while not being damaging to tissues. And I think right now we have solutions that are very able to effectively kill bacteria without being toxic to the surrounding tissues. And fortunately, our infection rates have become very, very, very low. And that's really basically what we call the last frontier in joint replacement, is trying to get rid of infection. And I think we're making a lot of headway in that regard. All right, so in terms of recovery, I think, we all hear about, the opioid epidemic. I think with the pain control techniques and the minimally invasive techniques, particularly on the hip side, we're finding decreased reliance on narcotics. I really, in my personal experience, I try to, give patients, a single, narcotic prescription, and sort of if they still need a refill, I try and have them come in and see them, because I just want to make sure, they're not struggling after surgery. And we've been very fortunate. We've really been able to lower our opioid use in patients, and I think it's been a really good thing, because we know that they can have pretty significant side effects in terms of nausea, vomiting, constipation, and things of that sort. In terms of activity after surgery, we are putting in these implants so that they are robust enough that patients are walking up post-op day 0, right? So they're walking the day of surgery. And really, the first 6 weeks, we just want patients to take it easy, but they definitely can walk as much as they can tolerate. And then in terms of going back to work, typically I would say that's about, 6 to 8 weeks for most jobs. If you have a heavy manual job, I like to be conservative and say 2 to 3 months. But I'd say most patients are able to go back to work in 6 to 8 weeks. And then in terms of sleeping, I think in terms of hip replacements, this has come a long way. With the anterior approach, since we're not cutting any muscles or tendons, the risk of dislocation has become, almost non-existent. And so we don't have a lot of positioning restrictions on patients. With the knees, we generally just want them to stay straight while they're sleeping for the first few weeks. But in terms of the hips, really, I think that's the main barrier, is patients can now sleep sort of in any position they want. I don't really have any restrictions on which way they want to sleep after surgery. And then in terms of, antibiotics, I think, we've found that, a single preoperative dose of antibiotics is typically sufficient. And definitely in the era of outpatient surgery, where patients are going home the same day, we really don't prescribe antibiotics unless they're having, they're a little bit higher risk. And then the other thing is that, I think a lot of patients come in and they say they have a penicillin allergy. It's a very common drug allergy, and it affects us, giving one of the more effective antibiotics for preventing infection. And we actually know that a lot of these penicillin allergies are either they're not truly allergic, or the rate of reactivity with the antibiotics we give is actually very low. And so we found that we can give the most effective antibiotics even in patients with a penicillin allergy. And then how long do I stay in the hospital? I think this is something that in the last 5 years, especially since COVID, there's been a huge push towards outpatient surgery. And I think for a couple of reasons, we've actually found that patients just have lower complication rates when they go home, lower infection rates, especially when we're doing these outside the hospital setting in like a surgery center or a freestanding surgery center. We found that patients who go to the surgery center are more satisfied. They have a lower rate of infection, a lower rate of readmission to the hospital, lower rate of complications. And this has probably been one of the biggest differences, where basically I would say 80 to 90% of patients are going home the same day. Obviously, there's still a role for patients who need to stay overnight if someone doesn't have social support or they don't have enough help at home. Obviously that's a role for where the hospital comes in and will keep patients for a night. But generally, we try and plan so that patients have the support they need when they go home, and we're shooting for going home the same day the vast majority of the time. Okay, in terms of preventing blood clots, typically, classically, we gave patients sort of injectable, blood thinners, or, things like Coumadin or warfarin. And we know that that actually led to a really high rate of complications in terms of wound drainage, because patients' blood was getting very thin. And it was leading to, a drainage from the incisions, and that's a bad sign, and it can potentially lead to infection. And so we've actually moved to just giving a simple baby aspirin twice a day, and that's been a huge difference maker in our efforts to combat the risk of infection, in combination with the irrigation solutions we spoke about. Obviously, some patients do have to be on, stronger blood thinners for heart conditions and things like that, and we work with your medical team to optimize and make sure that you can get, the least aggressive blood thinners possible. But obviously, we do recognize that, we have to give the blood thinners that patients need. And in those cases, we will definitely make sure we need to give them, and we'll work with our, your primary care doctor or the hospitalists to make sure that, you're getting the right blood thinner that you need. All right, I think that's it. I wanted to save as much time for questions as possible. So I'm happy to answer any questions. I'll let Karen take over from here.
All right, great. Thank you very much. Dr. Tarabichi, also, I just want you to know that was fabulous, so thank you. Great information.
Thank you.
Okay, so we received a question. Someone who now lives in Las Vegas, where the quality of medical care is nowhere near what they were blessed with in Barrington, is there such a thing as remote surgery and rehab where the person could fly in, have the surgery done, do initial rehab here, and then fly back to, say, Arizona?
Absolutely. I mean, I think, for local patients, we found that, I generally don't recommend traveling until 6 weeks after surgery, but definitely the era of patients traveling for their care is well and truly here. And I think that as long as appropriate measures are taken in terms of, the main thing I think we worry about is just blood clots. As long as appropriate measures are taken, some people, the TED hose stockings, like compression socks, with the aspirin, I think it's been as effective a blood thinner as any. I think our threshold for that is getting, lower and lower. So I think the era of traveling to get your joint replaced, and even just being, in the area for a matter of days, I think is here. It's certainly, it's not uncommon.
Great, that's great. I'm sure that person will be very happy to hear that. All right.
As long as Karen, as long as their surgeon is comfortable with it, that's the most important thing.
Great. Okay, perfect. And he had actually mentioned that he had an appointment scheduled with the surgeon before he moved, so maybe he can reach back out to that surgeon. So super. All right. Someone wants to know, do you replace the meniscus with a knee replacement?
That's a great question. So yes, the meniscus does come out when we replace the knee. So the meniscus is sort of, it's a C-shaped structure that acts like a cushion on both sides of the knee. And what you need to know is that as your arthritis progresses, that meniscus gets chewed up, and it really just acts as a pain generator. So when we do a knee replacement, that meniscus or whatever remains of it is cut out. And Great. So that basically what replaces the meniscus basically is that plastic liner that goes in the middle. That basically acts as your replacement of the meniscus.
And that won't send any pain signals to your brain.
There you go.
Yeah. All right. This question I don't quite understand, but you probably will, so I'm going to read it to you. They say it's never remembering pain that hurts. It's the real-time experiencing of the pain that hurts when it's occurring. Under the twilight anesthesia, what pain does the patient feel as the surgery is occurring?
So no pain. That's the goal. They will feel no pain. I mean, they may feel, sometimes, if that twilight sort of wears off, they may feel movement, pressure. But if I think the anesthesiologist will make sure that that's almost never happens. But the goal behind the spinal anesthetic is that patients are feeling no pain. So there's no sensation of pain. And that's how the spinal works. Actually, if we compare spinal and general anesthesia, patients' narcotic requirements during surgery are higher with general. So with spinal anesthesia, you are well and truly not feeling anything.
Awesome, thank you. Okay, someone had a total knee replacement 10 years ago in both knees, and their kneecaps have cracked 3 times. Do you have any idea what causes that to happen?
It's hard to know what someone means by cracked. I mean, if it's broken, if the kneecap is actually broken, that could be something that needs potential surgery, where they have to do potentially a revision or a redo knee replacement, or they need to fix the kneecap itself. But I'm not quite sure what they mean by cracked. Sometimes if the kneecap can dislocate, that's very, very rare. That can also be a source of something that needs a redo. But I think one thing that's important that you mentioned, because sometimes what happens is the patients form scar tissue, and when their knee glides, they may feel a sensation of crackling or popping. Most of the time it's benign, but if we're referring to actual crack where the patella or the kneecap breaks, that is potentially something that needs surgery.
Okay, great. Thank you for that answer. All right. If a person has stenosis, would they be someone for whom you would still recommend spinal anesthesia?
That's a good question. I'm not an expert on it. I think the one main factor that steers anesthesiologists away from spinal anesthetics is surgery.
Okay.
Previous history of spine surgery, because that introduces a lot of scar tissue in the spine and can make it very hard to do the spinal anesthetic. I don't think having a history of spinal stenosis is something that would stop them. But like, let's say you have a history of stenosis and subsequent surgery, that may be something that may steer your anesthesiologist towards the general anesthetic.
Got it. And so that would be more a question for the anesthesiologist than for the surgeon like you. Okay, super. Thank you. All righty. You mentioned getting back to work in 6 to 8 weeks. How quickly can someone get back to tennis or other activities following hip replacement?
Hip replacement, I think in particular, I always tell patients the first 6 weeks, I don't want them doing, anything strenuous, because that's when that bond between the bone and the implant is forming, and that takes about 6 weeks. After 6 weeks, I really tell people they can do whatever they want. So typically, I would release someone to, playing something like tennis at 6 weeks after surgery. Everyone's a little bit different. I think that I tend to be a little bit more conservative. Hip replacements feel much better very, very quickly. So even when you tell someone, not to do it, you may find that you're at their 3-week visit, they're already back to, running and playing tennis and stuff. And certainly, I'm not saying that's unsafe, but sometimes on the other side, sometimes people try and do a little bit too much, and they sort of regress. So I like to tell people, just take it easy for 6 weeks, let your body heal, and then you can go full tilt from there.
Great. And how about for a knee replacement?
Knee replacement, I would say it's probably a little bit longer, just by virtue of knees being a little bit harder of a recovery. I would say when can you go? I would say I'm okay with it again after 6 weeks. But I would say, knees probably a little bit longer, probably about 2 to 3 months before they're feeling much better. In terms of full recovery from a joint replacement, I would say for knees, it's typically up to a year. It doesn't mean that a patient is, unhappy for a year, but you continue to realize gains for up to a year. So, I tell people the first 3 months is like the 90% of the recovery, and then 9 months after that is that 10%. So you continue to realize gains for up to a year after surgery. And then typically at a year, I tell people, that's sort of that's the knee that you're hopefully going to live with for the rest of your life.
Great, thank you. Okay, do you do regular x-rays or CT scans prior to hip surgery for proper measurement?
That's a great question. So we typically just do regular x-rays, and we have something of a known size put on that x-ray, so we can, it's basically something that's about 2.5 centimeters wide. And so once we know that size of that, then we know how big your bones are, and then we can establish the sizes of the implants that we're putting in ahead of surgery. And that's the goal of every surgery. You should know what implants are going to go in before your surgery. And
awesome.
We do that for every single hip.
Great. Thank you. Okay. This person asks, do all the doctors at IBJI have the same philosophy and follow the same protocols as you?
That's a good question. I think by and large, we all, have the same overarching philosophy, which is, in terms of, patients having, significant arthritis, they failed on operative treatment, because we want to do a safe surgery with the best outcome possible. Obviously, in terms of like the minutia, like whether it's the implants we use or slight differences in technique that I described before, like the approach we use, whether it's a posterior approach or an anterior approach, or the type of incision you use on a knee replacement, whether you're going a little bit into the quad tendon versus not. Those are small differences. Like I said, the end product is pretty much the same. I would say most of us have very similar philosophies, but there are, subtle differences.
Great. Okay. Okay. Thank you. Okay. And now we're getting to the ones I didn't have time to read because they've come in since your program. So let's see. With 10 years of steroid injection, 3 to 4 times each year, could a knee replacement still be done under those circumstances?
Yeah, absolutely. That's not going to stop anyone from doing it. So the key thing about steroid injections, and that's a great point. If you're having them 3 to 4 times a year for 10 years, just know that overall, when you're getting steroid injections at that frequency, the steroids in there can actually have a net effect of breaking down the cartilage. Now, it doesn't mean your knee is going to fall apart or anything like that, but it does have that effect. That being said, I think that I always tell patients, if the steroid injection is typically working at least 3 months, I'm happy to keep giving it to them, because they can only typically get it every 3 months. And if someone is getting significant relief from the injection and they can avoid surgery, I think that's a totally reasonable option. So if someone doesn't want to have surgery and they're getting great relief from the injections, I think it's reasonable to keep getting injections.
Great. Okay. Thank you. All right. What is your preventative treatment plan for a person getting a hip replacement who had a prior DVT pulmonary embolism when they had a bunion repair?
Mm-hmm. So that's a good question. I think that some people, will typically use a more aggressive blood thinner, like the ones used to treat said DVT or pulmonary embolism. What we're finding, though, is that even in those cases, there is some data emerging that even in those cases, aspirin is safe. But I think most people would still err on the side of caution and use a more aggressive blood thinner. And that's what I would do in my practice.
Great, thank you. Okay. How long is the average knee replacement surgery, the surgery itself?
That's a good question. So I think it's variable. I would say, any surgeon who's doing these at a reasonably high volume is probably doing it in, 45 minutes to an hour. Obviously, there are variations. Some people are a little faster, some people are a little slower. But I would say, typically 45 minutes to an hour.
Great, thank you. Okay, someone would like to know how do you determine a partial versus a full knee replacement? Can you go into that maybe a little bit more?
Yeah, so there are some criteria which can be a little technical, but the main thing we look at is where the arthritis is in the knee. So like the most common type of partial knee replacement is called a medial partial knee replacement, where you replace the inside of the knee. And so if the inside of the knee is sort of like bone on bone or even are just arthritic, and the outside part is preserved, and then the area between the kneecap and your femur bone is preserved, that's typically when we'll do it. You can even do partial knee replacements on the outside of the knee. Those are a little less common. But typically that's the main criteria is, if just one part of the knee is affected, which we can see on x-ray, and that's really the main criteria we use to judge whether someone's a good candidate for a partial.
Great, thank you. Okay, let's see. As far as going back to work, could a patient go back sooner if they work from home, like remote computer work?
Oh, yeah, absolutely. Yeah. I think as soon as someone is comfortable at home, if they want to work from home, I've had patients go back to working from home within a matter of days after surgery. I think it's just the nature of your work, and whether you're on, like, if you're on narcotics, maybe you want to be off the narcotics before going back to work, and certainly patients are getting off narcotics sooner and sooner. And we've had patients go back to work very, very quickly if they're working from home.
Great, thank you. Okay, what kind of physical therapy do you recommend after a knee replacement?
So typically that's outpatient physical therapy. It's typically 2 to 3 times a week for 6 weeks. I think the big advance we've seen in physical therapy is that typically we would have patients start physical therapy within 1 or 2 days after surgery. And we've actually found that that actually is not that effective. We're now moving towards delaying the start of physical therapy. So even 1 to 2 weeks out from surgery, because, you know, initially when you do the surgery, there's a lot of inflammation around the knee, and having someone, you know, going into someone's office and having them crank on your knee 2 days after surgery, we found is actually, you know, it can make that inflammation worse and that swelling worse. So we've actually, at least in my practice, we've moved to, you know, I tell patients, you know, we do the surgery, you go home. For the first week, I just want you to ice, elevate, take it easy, no physical therapy. And then once that week is over, we'll have them start going to outpatient therapy, and that sort of that early like post-operative inflammation has subsided, and patients feel that much better when they start going to physical therapy.
Great, awesome, thank you. That's great to know. Okay, so when you're saying about resting afterwards, someone's asking, does the knee need to be kept immobile for a period of time?
No, it doesn't need to be immobile. We encourage early range of motion, but you know, it's the difference between doing physical therapy right away and just moving your knee with what we call activities of daily living. I think activities of daily living, like, you know, getting into a chair, getting out of a chair, I think those activities are fine. We definitely don't want the knee to stay, you know, stuck in one position for 1 week. We just don't want anyone cranking on it or, you know, doing aggressive range of motion in the first week. But we definitely want you moving.
Great, great. Okay, this looks like it's for hip. Do you find more edema with the transverse incision versus the longitudinal incision on your total hip replacements due to patient positioned in seated flexion throughout the day?
No, I don't think we've seen that. I mean, really, with the transverse incision, the operation is almost exactly the same. It's really just that initial skin incision. We haven't really seen a difference in terms of swelling. No.
Awesome, good to know. Yeah, that sounds really great. The fact that you can barely see it afterwards. I love that. Okay, let's see. How many years at this point are these newer hip and knee replacements lasting?
That's a good question. So with hip replacements, you know, I think that the initial hip replacements that were put in very early in sort of the 50s and 60s, we typically know that those were lasting about 30 years, okay? And the main reason was the plastic was falling apart. Now, the medical grade plastic that we're putting in today, we know that the wear rate is sort of less than 0.1 millimeter per year. And now that we're doing cementless hip replacements, we think that bond between the hip and the bone, or between the bone and the implant, is hopefully good for life. So theoretically, with hip replacements at least, we do think that, God forbid a complication notwithstanding, we think that hips are good for life. That should hopefully be the last operation you should ever get on your hip, okay? Obviously, it's a mechanical device. It's not an ironclad guarantee, but that's what we speculate. With knees, I would say, you know, it's a little bit harder to say with knees because a lot of these are put in with cement. We do know that the revision rate or the redo rate of a knee is basically 1% per year. So if you think about it, at 25 years, a quarter of knee replacements may need to be redone. But that's the historical,
Right.
historical knee replacement. That's the knee replacement. Sorry, just my light turned out here. The knee replacements, I think that's based on old data, and so
Right.
the jury's still out on how knee replacements are going to function in the future, but we think they're going to last a lot longer.
Great, great, awesome. Compared to an ACL reconstruction surgery, how is the total knee replacement surgery different?
So ACL reconstruction is typically done arthroscopically. I'll be honest, it's a little bit, outside my scope of practice, but it's typically done arthroscopically with two small poke hole incisions. The knee replacement is done through an open incision, so you actually need to open up the knee. It's definitely a more significant surgery. I think that ACL reconstruction, I would say, is generally, most people would agree, a smaller surgery.
Okay.
That's the main difference. Is in terms of the size of the surgery, is knee replacement, open up the knee to get those parts.
Gotcha. Okay, great. Thank you. Okay, you've already answered that question. You've answered a bunch that came in probably before somebody else asked it. So that's another, there are a lot of work questions. A lot of people want to get back to work, it sounds like. Okay. So should I be concerned that I have had 2 knee replacements, 1 hip replacement, and now the final hip replacement? Any precautionary concerns for me?
I don't think so. I think these are successful operations, and more and more patients are they're having all 4 joints replaced.
Yeah.
I don't think there's any. I think the only difference you'll see is, like, if you had your 2 knees and your hips done and your hip done a while ago, and you may just be surprised, hopefully, how much easier the recovery is. Hopefully, just because we're doing these in a less invasive fashion, our pain control is better. No, I don't have any concerns for someone who's had 2 knees and their hip replaced. I think it would just be like the other standard hip or knee replacement.
Good, good. Okay. Let's see. This just says, are there any contraindications for surgery or anything I can do to improve my outcome? But I'm not sure what would cause that person to have contraindications. So I'm looking to see if maybe they asked another question earlier, but I don't see it. So I guess, what are your general contraindications for surgery?
Yeah, that's I mean, that's a pretty broad question. I think things that the most common things we see contraindications for surgery are things like open wounds in your legs. Those are a potential source of infection, and we do know that if, God forbid, an infection happens and it goes to your hip or knee, that's it's a disaster. And so anyone with an open wound is generally not going to get surgery. Uncontrolled diabetes is very, very common. If you're I'm sure a lot of people know about the hemoglobin A1C. If that's more than 8, that's something where we would not do surgery. We would defer surgery. Super obesity or morbid obesity, that's a bit controversial, but generally I would say most people, BMI, I would say over 45 or 50, I think is where we would probably say we should probably try and optimize and try and attempt some weight reduction before doing surgery. And there's a lot of ways to do that now with a lot of the medications out on the market. And then in terms of improving your chances, the things that we're paying attention to now, a big one is nutrition. So like optimizing your nutrition, make sure you're getting sufficient protein so that your body's able to heal your wound and recover appropriately. That's the big thing. I think that we could talk all night about how to improve your outcome after surgery. But I think nutrition is a big one.
Great. Well, maybe that'll be your next talk. All right. How about this? We have a couple more minutes. Someone has no ACL. Would that affect the surgery?
No, it would not. And just so you know, not most, I would say all knee replacements currently available actually substitute the ACL. So even if you have an ACL and we're going in to do a knee replacement, we remove your ACL to perform the knee.
Okay, that's very interesting. Okay. How long can you expect to be in any significant pain after a knee replacement?
I would say generally the first 2 weeks are the hardest.
Okay.
Once you get past those first 2 weeks, patients start to feel much better. The first 2 weeks are, when the pain is most significant.
Great, thank you. And how soon can someone drive if it's the left knee, and how soon can someone drive if they have their right knee replaced?
So if it's your left knee or left hip, I will tell people as soon as you're off narcotics, you're okay to drive in my book. With a replaced hip or a replaced knee, I think hips probably recover a little bit faster. With the knee, I mean, I generally say 6 weeks. The main reason is because you need to be comfortable slamming on the brakes, right? God forbid you don't want to be at fault for something if you can't slam the brakes. And usually I'll tell you most people that's at about 6 weeks for a knee, as long as they're off narcotics. So I typically see patients at 3 weeks and 6 weeks, and depending on how they're doing, if they're far past where they usually are, I'll tell them, hey, go into an empty lot, make sure you're comfortable slamming on the brakes. But 6 weeks, if you're having surgery on your right side, typically it's 6 weeks.
Great. All right. I don't want to keep you past 8 o'clock. Thank you so much, Dr. Tarabichi. Also for making so much time for all these questions. It was super helpful. For those of you whose questions I did not yet get to, please reach out to Dr. Tarabichi and ask him your questions in person.
Okay.
Dr. Tarabichi, good.
Thank you so much.
Thank you for your time. Have a great evening, everybody. And thanks, Dr. Tarabichi. Fantastic program.
Thank you. Have a good night. Bye-bye.
Good night.